being here for this. I'll just qualify by saying right up front that the United States healthcare system is not one that any country should aspire to. It's one that we have that we're trying to transform and correct. And quite frankly, we need all the help we can get, because there's things that are good in it, but there are a lot of things that actually are obstructionist towards us getting to a person-centered, high-quality healthcare system for all. So with that, let me just outline a couple of the issues. First, we have 50 million uninsured people in our country. We have 308 million, so it's about 17% of our population. It's about the size of Spain. It's 19 of our states combined, 50 million uninsured people. And of course, when you've got that many uninsured people, you've got a real have and have not system with a lot of people living sick and dying young. Second is that we've got the wrong focus on our healthcare system. In our system, it's all about disease. We've got the best, maybe, sick care system in the world, but we have far from the best healthcare system in the world. Because what we're better known for is doing things to people than preventing them in the first place. We've got the wrong delivery model based on, again, this sick care approach. We don't have enough primary care physicians. We're undermanned. We've got the wrong field on the team, the wrong team on the field, at a time when we're trying to provide high-quality, timely access to all. We've got staggering costs because of this, and I'll talk a little bit more about the costs in a second. And we have quality problems. You'd think if we were pumping in the world's largest amount of money into our healthcare system that would have at least close to the best healthcare system in the world. But when you take a look at the WHO rankings, the United States ranks 37th in the world for our healthcare outcomes. And that's one position below Costa Rica. And again, not that Costa Rica doesn't have a good healthcare system, but I'm shocked that the United States doesn't have a better healthcare system. And of course, we have a lot of healthcare insurance problems. It's a problem for us in our country when we have CEOs of health insurance systems making $20 million a year, when the whole purpose of most of our private health insurance systems is to make money for stockholders, not to provide the care that they're entrusted to pay for to the American public. So what I've come to recognize with the United States healthcare system is that we just have a massive fire department. We have people that come in on fire. We don't prevent them from being on fire, of keeping them healthy and functional. We actually profit from them being on fire. So coming in sick, we'll pay pennies on the dollars to control their hypertension and diabetes and mental illness, but we'll pay tens of thousands of dollars on the back end to amputate legs, to put them on chronic renal dialysis, or to pay for heart attacks and stroke care. So that's the amount we pay per year, $2.8 trillion, $2.8 trillion. That's the largest sector of the entire American economy. The American economy is the largest in the history of the world, and this is the largest sector of the largest economy in the history of the world. And we're pumping it into a healthcare system that's not producing good healthcare outcomes for our people. This is the graph showing the expenditure of finances over time. 1960 here, we had $27 billion a year that was going towards healthcare. Here in 2012, roughly $2.8 trillion a year, and the projection out from CMS, which is our Medicare and Medicaid system, is an expansive growth. If you take a look at the consumption of our gross domestic product, this graph kind of says a lot. We had 3.8% of our GDP going towards healthcare in 1935. It's at 16% in 2009, it's 18% today, 25% in the year 2025, and 50%, one out of every $2 being spent in the entire American economy going towards healthcare in 2082. So you can see the implosion of our whole system based on the finance of healthcare. At a time when we have 10,000 people a day turning age 65 in our country and will so for the next 20 years, you can see the magnitude of the problem. We have a tremendous amount of money being focused and pumped into our healthcare system, and we must get to a much better focused, person-centered system that's really planning and working with people to keep them from having the problems, managing them well, having their expectations being controlled, having them be part of the system, and for us to coordinate better end-of-life care. And that's part of the major challenges. So with that, as a lead-in, I wanted to talk again and then about the Patient-Centered Primary Care Collaborative, which is a national effort in our country's part to kind of re-center our healthcare system on to primary care. So as you can see in this particular slide, I've covered several of the points on the left there in terms of our rising healthcare costs, our gaps and variations in quality and safety. Because when you have a have and have-not system with 50 million uninsured people, you've got a tremendous amount of variety and variation in care. You've got the haves that can get an MRI tomorrow if they want it, but you have the have-nots that can't get care at all. And then when they do access health care in our country, they go in the wrong healthcare doors. They're going through the emergency room and the hospital, when good timely primary care access would control much of the problem and keep them from starting on fire, if you'll allow me to use that metaphor again. Below average population health, again, I mentioned we rank 37th in the world. Increasing age of our population, which I referred to, and increasing chronic disease. We have a perfect storm, really, again, for a major, major problem. And that's why this became such a big issue in our country, both in 2008 and 2012 with our political elections, because part of what the national referendum was on healthcare reform. It was a big deal. President Obama ran on 3 major issues. One was reform of education, one was reform of energy, and one was on reform of healthcare. So the PCPCC, known as the Patient-Centered Primary Care Collaborative, was again an effort nationally to help restore a strong foundation of primary care around the concept of the patient-centered medical home. This is a symbol, if you will, for how timely quality access can happen at the primary care level. And its purposes of the PCPCC was to disseminate results and outcomes from medical home initiatives and their impact on outcomes, quality, and cost. Because one thing is really true in the United States, and that is, show me with data. If you don't have data, then we'll keep the status quo just as it is. The second was to advocate for public policy that advances and builds support for primary care in the medical home. And lastly, to convene healthcare experts and patients to promote learning, awareness, and innovation of the medical home model. The medical home became, if you will, the transformational symbol of restoring a primary care-based system. Because one of the things that happens in other countries, and I know I'm preaching to the choir to a certain degree, is that when you get outside the United States and you look at healthcare systems that are doing better than ours, it's got a much better mix of primary care. So the PCPCC was founded in 2006. It represented a group of large employers and primary care physician associations to facilitate improvements in the patient experience, health outcomes, and healthcare cost control, and to get us to a much more efficient and effective healthcare model. It looked at itself as playing a convening role to bring together thought leaders and stakeholders from across a very broad continuum who very much were happy with the system just as it was, thank you, to address these challenges, opportunities, and barriers to healthcare system transformation. You have to understand that we have a system perfectly designed to do what it does, and what it is designed to do is to make money. It's not to generate health, it's to make money. And so it's perfectly designed to do that. And that's part of our challenge, is how do you disconnect then a $2.8 trillion system that's making a lot of people a lot of money to get back to a better health generating system. So the PCPCC became, if you will, the high-level organization outside of the federal government to try to do this from an employer-based system with a lot of different stakeholders. So the membership of the PCPCC now has 1,000 organizations. So if you will, it's an organization of organizations. The big piece is that of these 1,000 organizations, 400 of them are the Fortune 500 companies of the United States. So we have Exxon and Walmart and IBM, Microsoft, Google, all of the major companies are a part of the PCPCC because they're all going broke on healthcare costs. And so there's a tremendous incentive from large employers to try to get this under control. So we have the larger provider associations, the American Academy of Family Physicians, the American College of Physicians, the American Academy of Pediatrics. We've got the large employers, as I just alluded to. We've got large health plans, because you can see that the health insurance systems of our country would benefit from providing more timely preventive care than higher cost downstream care. And in fact, it would seem intuitively obvious to you that it's less costly to take care of healthy people than it is to take care of sick people, but that's not how our system is constructed. Providers and health systems are a part of this, pharmaceutical firms, policymakers, and patient advocacy groups. It's to try in our country to get all the key players together. Because Winston Churchill once said about America, and I think Sir Winston really had us pegged as a nation, he said, America will always do the right thing after it tries every other option. And I just think that Sir Winston knew kind of the heart of the American. So in the PCPCC, to try to help attack the problem that I've just outlined, we have 5 major centers. First there is Care Delivery and Integration Center, and I'm the co-chair of that particular center for the PCPCC. We have an employer and purchaser engagement side of this, because again, it's all about money and it's all about controlling costs. Employers, again, are a big part of that. Patients, families, and consumers, to make sure that it is focused on who we're trying to help, which are the people of our society. Outcomes and evaluation, so that indeed we can measure things and show change, because again, if you can't provide the data to people, they're not going to just change because you talk about it. And then advocacy and public policy, because it is all about making sure that people are aware of the health policy implications. So this medical home and health system transformation was all aimed at getting us to a higher strategic objective, which was what in our country has become called the triple aim. Improving the experience and quality of care, improving the health of populations, and reducing healthcare costs. That became our national strategic quality objective. Before the Affordable Care Act was passed in 2010, we did not have one. So how do we get there? The redesign of primary care, partnering with individuals and families, population health management. We need to develop a much more community-facing approach than what we now have. Ours is an individualistic approach that's reactive in nature, not proactive, community-facing, individual and person-facing. And healthcare system integration. We just don't talk to each other in our country. Why? Because we don't get paid to talk to each other in our country. We get paid to do things, not to coordinate things, not to integrate things. So again, you just have to understand the incentives. So this medical home is patient-centered, it's person-centered. It's about, again, what people need, not what the system needs. It's coordinated, utilizing what's termed the medical home neighborhood, i.e. how the subspecialists and different community agencies interact. It's accessible so that people can gain access to the system. We make much more use of electronic forms of information and emails, telephone calls, etc., to try to help coordinate and integrate. Committed to quality and safety. Again, for all the reasons mentioned, our system just doesn't generate that as an outcome, and it needs to be comprehensive. What was really well understood is that the more comprehensive the system's knowledge is and the provider's knowledge of the patient is, then the more integrated and coordinated, the more timely and the more cost-effective that care is. So the results and evidence have been really good, and I'll just summarize this complex slide by saying it is shown across the board reductions in ER utilization, hospitalization, and cost to patients. So we're on our journey to make sure that we try to get to that next phase. We will in the United States, because we can't afford not to. It's too costly of a system. So with that, I'll stop there. I know that I've provoked some thought, and I look forward to the questions that will follow.